How would you compare and contrast the strategies that have worked for Stanford versus these larger players?
Our strategy is really built around what we call the 5 Ps. So we pursue partnership strategies. So even though we are very proud to be independent and very confident in our ability to remain independent, there are times when we recognize that there's an opportunity for us to partner with a larger health system, either for clinical services or for brand purposes. Our second P is our programs. So building out a full range of comprehensive services, and where we can, providing a high level of sophistication so that people don't need to travel for care. Our third pillar is patients as consumer, recognizing that we need to provide the highest level of service. Lastly, we focus on a set of performance capabilities, things like financial sustainability and our digital solutions that help make the other 4 strategies really hum.
Welcome to the Analyzing Healthcare podcast, brought to you by Scale Community. Scale is a global healthcare-focused member network where healthcare leaders come to connect, learn, share ideas, and shape what's next in our evolving healthcare landscape. To take advantage of all that Scale Community has to offer, from expansive content to virtual and in-person events to interactive peer networking opportunities and more, check out Scale Community at www.scale-community.com. Membership options range from free to paid, so if you enjoyed today's discussion, please take a moment to sign up for your preferred membership level. All right, welcome to the next Analyzing Healthcare by Scale Community episode. I am pleased to be joined today by Ben Wade. Ben is a Senior Vice President and Chief Strategy Officer at Stamford Health here in Connecticut. Ben, welcome to the podcast.
Hi, Jason. Thanks so much for having me.
So maybe I think we're going to get into a bunch of different topics today about partnerships, about your outpatient strategy, about some of the impact of certain regulatory changes and how you've been navigating through that. So lots to cover, but always helpful to put that in context. And maybe we can begin with that context. So for those that are less familiar with Stamford Health, if you can give a quick overview of the hospital's footprint, and broader than that, maybe just a little bit of insight into the broader Stamford Fairfield County market. What are the unique attributes of that market that define delivery of care in that geography?
Sure. So Stamford Health is a single hospital, independent, not-for-profit health system. We employ around 4,100 individuals, including about 350 physicians. And we are a $1.25 billion health system. So in the grand scheme of American healthcare, we're kind of mid-sized, but in our market, we're actually a smaller player. We're surrounded by very large health systems. Yale New Haven Health is in our market, as is Northwell with a recent acquisition of Nuvance, and Hartford Healthcare, as well as all the New York City systems. We are the most advanced and sophisticated provider of acute services in our market. We have, for example, the only open heart program, the highest level trauma center, but we are a lot more than just the hospital. We have a very large ambulatory footprint. Actually, and I know we'll come back to this, ambulatory services make up about 70% of our revenue, which is unusual for a hospital our size. And that's made up of our medical group, which is the most comprehensive medical group in the market. We have a large primary care base as well as a full range of specialties. And then we have a very large imaging and a very large lab platform. Our primary service area is the city of Stamford, which is a community of about 160,000 people, a very diverse community. But we serve, if you think about the shape of Connecticut, there's that little square off the side of the big square. We basically serve that whole little square. And that is a community of about 350,000 folks. And it includes some of the wealthiest communities in America, towns like Greenwich and New Canaan and Darien. But the city of Stamford itself is quite diverse. And in fact, we have the second highest rate of uncompensated care of any hospital in the state. Last year, we provided $170 million of uncompensated care. So it's a very diverse market. And very competitive.
Well, you mentioned the cardiology program. So I'm just wondering if you were to, as a chief strategy officer, so you're thinking about the system strategy and comparing that versus some of the larger players that surround you. What has Stamford Health had to do in order to carve out its niche and remain relevant and stable and continue to be one of the largest providers in that Stanford market. How does strategy differ from some of the other players that are larger? Is it more focused on high acuity services, trauma, the cardiac program that you mentioned? Is it more focused on community engagement? How would you compare and contrast the strategies that have worked for Stanford versus these larger players?
Yeah. So, I'd say first off that we are large enough that we have scale. So, and if you look locally, because all of healthcare is local, we are very relevant and have a very broad range of sophisticated services locally for our community. Our strategy is really built around what we call the 5 Ps. So we pursue partnership strategies. So even though we are very proud to be independent and very confident in our ability to remain independent, there are times when we recognize that there's an opportunity for us to partner with a larger health system, either for clinical services or for brand purposes. And for example, we have a great relationship with HSS, the Hospital for Special Surgery in New York, U.S. News and World Report's #1 orthopedics program. Done a partnership with them, and they provide orthopedic services exclusively in our region here with us. We have another partnership with Columbia, not only on the teaching side, but also for cardiac services and neurosurgery, and a partnership with Dana-Farber Brigham for our cancer center, which is a little bit deeper and more robust than the traditional name on a lab coat partnership that academic medical cancer centers tend to do. Then we also work on developing, our second P is our programs. So building out a full range of comprehensive services, and where we can, providing a high level of sophistication so that people don't need to travel for care. Our third pillar is patients as consumer, so our third P. And that's about recognizing that we need to provide the highest level of service and also meet patients' changing expectations when they're shopping for care. And so pursuing a full range of consumerism strategies there. The fourth is partnering with physicians. Our medical staff is 1,100 members strong, and only, as I said before, 350 of them are employed by the hospital, which means we still have a lot of independent physicians. And so we want to make it a great place for them to work and practice. And then lastly, we focus on a set of performance capabilities, things like financial sustainability and our digital solutions that help make the other 4 strategies really hum.
Well, it's interesting when you mentioned about 300 providers or 350 providers that are employed by the health system. And then I think I also caught that you said 70% of revenue is from outpatient services. And so I'm just wondering if you could dig a little deeper on that. Firstly, it stands out that a health system to be 70% outpatient stands out as, I would think, different, because when I think of health systems, I think of much heavier focus on inpatient. How does that 70% number compare versus other health systems that you've experienced and had insight into?
Yeah, I mean, that figure can vary wild. I know that there are some hospital-based health systems that have very small ambulatory footprints, especially if, everything is happening right on the hospital campus and they don't have a medical group. And then there are others, if I look at the average, among our competitors, it generally is in more of the 50 to 60% range. For us, we recognize that if we were going to be able to compete with these large health systems, we needed to be able to meet patients where they were. And so that meant building first a really strong primary care base that we could extend out beyond our traditional hospital footprint. And then as we built on our primary care base, adding on specialty services. And then once that was at a certain scale, then we could add on imaging services, more advanced imaging services, and ultimately things like ambulatory surgery centers. And so it was a very deliberate process to look out into the markets where we had growth opportunities, into our secondary service area, where also the payer mix was more advantageous. And then slowly, year over year, systematically make about $25 million of ambulatory investment every year. So we don't really think of our ambulatory strategy as something that you do in a big bang, the way that you would some other more inpatient focused strategies. This is really like part of our annual CapEx to just help us continue to grow. And it's been successful. We've been able to maintain our market share on the inpatient side in Stamford, and in our secondary service area, we've seen multiple percentage point growth just by investing in that ambulatory network and then doing a good job of providing good service to our patients and keeping them inside of the network.
If you look back over, let's say, 10-year period, so back to 2015, 2016, do you have an estimate of the ambulatory mix as a percentage of the total revenue for the health system? Would you say 50-50 at that point, 25-75 in favor of inpatient?
Gosh, I'm not getting the number exactly. But I will tell you that when I started, and I started about 8 years ago, we were, I would say, in the high 50s, low 60s. So it has been an increasing part of our overall portfolio. And, partly that we know that that's just where care is moving, right? Care is moving to the ambulatory side. If you want to catch that growth, the growth is going to come on the outpatient side, not on the inpatient side. And it also makes us more indispensable to our community because we're actually embedded and close to where they live and where they work.
And is that mix also driven by investment in things like ambulatory surgery centers? I know you mentioned, imaging centers, but are ASCs a big part of that outpatient strategy?
They are. So we're in a position where we still have capacity in our main ORs. We have two main campuses with ORs, our hospital campus, and then we have a very large outpatient facility called the Tully Health Center. And across the two locations, we still have OR capacity. But what we've seen is that there's an opportunity for us to provide lower cost, more convenient services to patients outside of our primary service area. And so we have one ambulatory surgery center in partnership with a group of independent physicians. And we are, always looking for opportunities for additional partnerships. So not only is it a way for us to provide lower cost care for patients and more convenient care for patients, but it's also an alignment vehicle with independent physicians. And that provides a dual benefit.
I mean, there's a few sort of common critiques of healthcare in terms of what and who is driving the rate of inflation in the market. But one of those would be payers, and the other would be hospitals that we hear, quite frequently. And I think it's interesting to see a hospital that's taken a very proactive approach to investing and building the outpatient footprint, to driving down the cost of care through that ambulatory infrastructure. And so I'm wondering along the way, how has Stamford been rewarded? It sounds like you've really played to the community. And so I'm sure the community appreciates that and has rewarded Stamford Health by coming to the system. Are there other stakeholders that have rewarded Stamford Health for building this ambulatory infrastructure? Payers, employers? It sounds like strategic partners, perhaps.
Yeah, all of the above. I think first and foremost, it's about providing care that the patients are looking for in the way that they're looking to receive it. But the fact that we have lower cost offerings in our portfolio, whether that's a lower cost imaging JV in conjunction with a group of independent radiologists, or this ambulatory surgery center that I was talking about before, it does give us an additional set of services that we can discuss when we're talking with payers about the services that we offer and the benefits that we can provide to their members. I think also from the perspective of elected officials and state level actors, they're happy to see us continuing to innovate in the way that we do and to provide greater access to patients and communities that maybe didn't have as convenient access before. One of the things that surprised me was that in our secondary service area, there was a physician shortage against national benchmarks. And this is one of the most densely populated suburban areas in the country. And so we're able to talk to state level actors and say, look, we're looking to make an impact on access to preventative care, not only in our home market, but in other communities that we serve.
It's interesting because you've mentioned a few different ways that the hospital has perhaps sacrificed immediate gratification for long-term sustainability. So building an outpatient footprint, I would say, is one. Sacrificing, higher cost of care that could benefit the health system financially near term, but you've built something that's more long-term sustainable and better fit with the community. I would say partnerships was potentially another. You mentioned HSS. So it sounds like you've given up part or all of an orthopedic division in exchange for having a really high quality partnership with a high quality orthopedic institution. I'm just wondering if you could take us into a few of those partnerships and give us a glimpse for the rationale for why the hospital made that trade and how it's played out and how you've benefited from partnering with some of these organizations along the way.
Sure. So I'll do two. I think it always begins with an unmet community need. And in the case of orthopedics, for example, we saw that there were 2,500 orthopedic procedures that were leaving our market and going down to New York City. And there was no reason why, based on scope of services, we couldn't provide that care just as well locally. And we knew at the same time that HSS was landlocked. They had more demand than they knew what to do with, not only from New York, but from the surrounding regions. And so we thought there could be an opportunity for us here to collaborate on a joint venture, not a new business entity, sort of like a contractual synthetic JV. And through the development of that, allow both parties to win when we grew our orthopedic program here at Stanford. And so, the key components to that, in addition to building up our scope of services, was to have a level of integration on the financial side and on the governance side that mirrored the level of investment that we were looking to have from our partner. So we needed to be willing to give away some of the upside on the technical component and some governance control over our orthopedic service line in order for them to make a commensurate investment in us. But it's been very successful. This coming year, we're anticipating doing 3,000 orthopedic procedures. So we've I don't know how many are still going down to New York, but we've more than brought back the number that we were losing out of our market down to the city as a result of the partnership. Our relationship with Dana-Farber, similarly, it originated as a relationship where they came in, they did an assessment, they gave us a little gold star that we were able to use in some branding, and we worked diligently to make improvements based on the ideas that they gave us in that assessment. But we really wanted something where they were invested in our growth. And so we approached them with an idea of developing a more integrated financial and governance model based in part on the success of our HSS relationship, where they would benefit from receiving a portion of the margin that came from growth over a baseline. And then similarly, we created a joint operating committee with them so that we could make decisions together about the investments that we were going to make. And through that, we got access to their clinical protocols. We agreed to provide care in a manner that's consistent with the way that care is provided in Boston. And we got some branding opportunities for our physicians as well, so that they could be called collaborating physicians. So those are just two examples. We also have done smaller relationships with smaller organizations. We think that we're a great partner for innovative startups, like an organization called ULA, which is a real rocket ship of growth done in New York City for midwifery services, or collaborative model between midwives and OBs. And we recently opened our first location with them in our secondary service area, and that's exceeding our early expectations. We actually just had our first ULA baby this past month.
Healthcare leaders, if your revenue cycle management is underwhelming you, it's time to rethink your current suite of solutions. Scale Healthcare's AI-powered RCM solutions are purpose-built to protect and accelerate revenue across the entire lifecycle. Denial Shield is an AI solution that proactively prevents and automates the resolution of denials, stopping revenue leakage before claims are even submitted. Front Desk Shield supports preclinical, administrative, and front-end RCM functions, incorporating eligibility, prior authorization agents to eliminate friction early in the patient journey. Revenue Shield maximizes revenue by automating coding, charge capture, and revenue integrity functions, ensuring accurate and complete reimbursement. Together, the Shield suite helps organizations reduce operating costs, capture missed revenue, accelerate cash flow, and increase productivity without ripping and replacing existing systems. If you're ready for immediate ROI and measurable impact, visit scale-healthcare.com and see how the Shield suite is redefining AI-powered RCM. Wow. So if we were to kind of create a list of successful partnerships and what criteria sits beneath those successful partnerships, top of the list would be a tangible need. Orthopedics, you're losing cases down to New York City. And so there was and HSS had their sort of reciprocal need. And so you found a synergy between the two organizations. So number one is tangible need. Number two, it sounds like deep commitment and deep integration. I heard governance, shared governance in both. I heard structured JV in both. Financial commitment, it sounds like in both. The hospital, Stamford Health, gave up something in both scenarios to get something in exchange, and vice versa. So not fleeting relationships, deeply committed, highly structured relationships. What other criteria would you say, make that list for a successful partnership from your experience?
Yeah. So yeah, you did a great job of listing out some of the really important factors. I think the last one that I would say is a level of cultural synergy. Partnerships are really, really hard. They're hard to build and they're hard to maintain, and they're really hard when they end, just like any meaningful relationship in your life, business or otherwise. And so, I think you want to make sure that not the organizations have a similar way of seeing the world and a similar way of operating. Not that you can't learn from each other. And certainly we've learned a lot from our partners, and I hope we've taught them things as well. But you need to know that the people on the other side of the relationship are the kind of people that you can get in the trenches with and solve thorny problems. Because the early stages, especially of a partnership, while you're dealing with change management and opposition from stakeholders inside or outside your organization, you need to be able to feel confident that you can lock arms with the other person and move confidently together through the challenges.
When you think about the needs and the opportunities for Stamford Health today, looking forward over the next couple of years, are there other partnership areas that you're thinking about? I mean, you mentioned ULA and the
Yeah.
delivery space, but any other areas that sort of are rising in terms of level of attention given needs and opportunities that you're confronting?
I could tell you, but then I'd have to kill you. Okay, we're actively exploring some partnerships right now, but I can't speak about them.
Are there areas, as you think about the redefined Stanford Health, that partnership is not really a strategy that is on the table or relevant because they're core services that you need to own, that you want to have remain in-house?
Yeah, I mean, I would certainly say that I would not want to, I wouldn't want to give away certain services. Like I wouldn't want to give away our primary care base or our medical group. That's not to say that someone couldn't come into the market with a value proposition for something that's complementary to the way that we provide care, even for something as foundational as primary care, and that we wouldn't consider that partnership. But we have looked at primary care partnerships in the past and have not found that they would be accretive to our system or frankly to the community that we serve. But I would never say never.
Do you think the consolidated private equity players make for viable partners for a health system? So for example, working with a consolidated physical therapy player or a consolidated cardiology player, uh, versus just looking to other health systems for partnerships?
Absolutely. Absolutely. We haven't done this, but there are some, well, first off, I should say, our emergency department physicians are employed by USACS, which is a PE-backed emergency professional services company. And they're a phenomenal partner to us. And so, it didn't even spring immediately to mind because they're so embedded in the way that we deliver care that I generally just tend to think of them as part of our medical staff and part of the hospital. But there are some other specialty players in the market who have been, rolled up into ever larger PE-backed physician groups, and we've sought opportunities for partnership. We are, as I said before, open to ambulatory surgery centers, and they might be looking to JV an ambulatory surgery center, and we'd be open to doing that. So if there's alignment of needs and a community need that we can meet together, certainly we're open to that.
Yeah, I mean, it strikes me that Stanford Health is quite deliberate in its planning. You don't get to be a 70% outpatient shift as a hospital system without a deliberate approach to planning, and you don't get to this network of strategic partnerships without being very deliberate in your planning. And
Well,
so
thank you. I'm glad that it comes across that way since that's my job.
it does. So what are you planning for next? Partnership aside, what are some of the trends that are evolving in the Stanford market that you're thinking about at a national reimbursement or regulatory level that you're thinking about? As you look out over the next couple of years, what are the key trends that either keep you up at night or get you excited in terms of Stanford Health's future?
Sure. Well, a couple of things I would say. The first thing, and it's something that keeps me up at night, is some of the eligibility changes that are coming as a result of HR1, the One Big Beautiful Bill. We've run some numbers based on data that we have from the state, and we're anticipating that around 8,500 members of the Stamford community might be at risk of losing their eligibility for Medicaid, which we call Husky in the state of Connecticut. And that could have really deleterious effects on their health. And, we already are spending $170 million on uncompensated care. And so having more people uninsured in our community is a financial risk to the organization. And so as soon as the One Big Beautiful Bill was passed, we sprang into action. And our CEO had a conversation with Mayor Caroline Simmons of Stamford, and we've pulled together a community-based collaborative that we're calling the Husky State Covered Task Force. And through that, we're going to work to connect people to job opportunities, job training programs, volunteer opportunities. We're going to work on our own and through our community partners to educate people about the new requirements. And then we're going to bring all of the Medicaid billers in town together to make it really easy for us to share information with each other about the new requirements and how we're changing our eligibility check processes and our interactions with the state to help patients out.
And can you talk a little bit more about that, the community aspect of bringing these Medicaid billers together? What type of information you're sharing, and what some of the initiatives are to drive enrollment?
Yeah, so in part we're kind of waiting to find out. There's a cascade of decisions that need to be made, first at the federal level, then at the state level, and then down locally. But we're bringing revenue cycle leaders. We haven't yet. We've had one meeting, but we will be bringing revenue cycle leaders together, and we're going to talk about how are we educating, just some ideas, how are we educating our frontline enrollment folks on these new requirements? Are there common pieces of collateral that we can use across all of our organizations? If there's new data sharing requirements from our organizations up to the state to make ex parte renewals easier, how are we organizing our systems to make that possible? So we're still in the early stages of figuring out that component, but I think it will be helpful, especially because there's a certain level of scale that we have at the hospital that some other providers in the community don't have. And so if we can put some of the thinking in place and just give them ready-made solutions, hopefully that helps us all by keeping more people enrolled who are eligible.
Again, another version of this theme that we keep hearing in this conversation, which I love. I mean, healthcare organizations are being asked to do more, and the challenges that you're confronted with are growing and evolving. And so I think what I see consistently across this conversation is that instead of taking the approach of we have to do all and more in-house and take it all on ourselves, you've leveraged a portfolio of strategies and resources and really pursued a theme of collaboration and really knowing what your niche is and what your strength is, and then looking to other community resources or external partners to solve for pieces that can make your value proposition stronger in the community. Kudos to you, and thanks, Ben, so much for the time, for stopping by to share a little bit about where you're focused at Stamford Health.
Well, thank you so much. It was a pleasure.
Thank you for joining us on Analyzing Healthcare. Stay informed and stay inspired. Don't forget to subscribe and visit scale-community.com to become a Scale Community member. Until next time, keep exploring the ideas that shape our healthcare systems.